It's always a pleasure to come and talk about this disease because what I keep telling my patients, some of them are around here, is that this condition has been around for more than 200 years now. And yet, from all what we've been hearing since morning, we still do not know what exactly is causing it, whether it's 10 diseases, whether it's 20, whether it's 30. All what we can say is that it's not one disease, okay? And what we do in our group is actually to use genetic approach to try and understand the disease. Now, most of what is in my slide, most likely you've had it at some point today. So it's really going to be a very quick presentation, which is good because it's later in the afternoon. We all want to go back home. Okay. All right, technologically challenged. Okay, I think I'm doing it right. Okay, so that's the most important slide, except that I work for Duke. Okay, so that's the way in which I look at nephrotic syndrome, water everywhere, but not a drop to drink. So essentially when you look at the patient, it's like the patient is, swollen up, but the water is actually not in the right compartment. The right compartment is supposed to be the blood vessel. Okay, so those are some of the objectives, and some of these I will actually jump because you've had it all today. Okay, so this is a patient that I looked after recently. So it's the plastic surgeons that I usually do before and after. We actually do before and after in nephrology too, and this is the before and after. So this is this child, presenting to me, and that's the. So where's the flash? How do
the top red.
Mm.
That makes the slide.
Oh, wow, interesting. Okay. Okay. So he basically came to me and, he's been to the primary care doctor. He's been treated for allergy for about a week, and then, he got all the allergy medicine. Things weren't getting better. Then he got swollen, and he came and, I think we know what is going on here. So anyway, check the urine, found that he had protein in the urine, do some additional tests, and then we made the diagnosis of nephrotic syndrome. Of course, he's 4-year-old, and then we started him on steroid therapy, and that's him like 2 weeks later. Okay? Happy ending story. This is what we want to see. Unfortunately, this does not happen in more than 50% of cases, and the challenge is actually to identify what should be what we are working towards, as you've heard from Dr. Gibson, is we want to get to a kind of situation where we have the patient in front of us, and then we'll be able to say, this is the patient that will respond to steroid. This is the patient that will respond to cyclosporine. This is the patient that will respond to all the other agents that will come forward. And that's actually the sum total of all the efforts in terms of clinical research, epidemiologic research, bench research, genetic research. So the other problem with doing research on this condition, and this is just to add on to what Debbie is saying, the other problem with doing research with this condition is that, quite unlike things like diabetes, hypertension, it's not a common condition. So if you say you want to do a clinical trial, you want to look for risk factors, you need thousands of patients. So it is one condition and where we need collaboration between the doctors, the parents, advocacy group like NKI. So you can see that, the prevalence is about 16 to 100,000 children. Now, it's not common, but sitting in my clinic, in my ward, it is common. Because one out of every 3 patients that I see will come with this condition. Okay, so what do we know about the epidemiology of nephrotic syndrome? Like most conditions, being a boy is bad luck. It's found more common in boys than girls, all right? But the other thing that we've noticed about nephrotic syndrome, more interestingly actually, is that there's actually some predilection based on ethnicity and race. For example, we know that nephrotic syndrome that is responsive to steroid is more common in people of South Asian descent. So people from India, Pakistan, most of India's subcontinent, 80% of them, majority of them, when they present with nephrotic syndrome, they will respond to steroid. And it's actually more common in them than the rest of the population. In fact, there are a couple of studies from, initially small studies from Europe, but more recently a large study from Canada that actually showed that the prevalence in people from South Asia is actually about 7 times more population. So that's one point. The second point is you would have expected that because it is more common in that population, the condition will be more severe in that population. No, it's the other way around. When you take the overall prevalence, it's not very common in African Americans and it's not very common in Hispanics. However, the severe form of the condition is actually more common in African Americans and Hispanics. Okay, so the summary of all this is that there must be some genetic component. Some people must be predisposed to developing nephrotic syndrome, and that's where gene-environment interaction comes into play. Okay, so gene is you're born with something that predisposes you to the condition, then there's that second trigger in the environment. And the part that I will concentrate on today is actually the gene. I have some data on the environment part of it too, but the time is very short and to be able to come to that. And it's one of these conditions, so nephrotic syndrome is one of these conditions that when the patient comes to the clinic, okay, so they just say diagnosis is nephrotic syndrome. Really, we are not really too sure of the type of nephrotic syndrome until when we've used our first line of therapy, which is corticosteroid. And that's actually, you heard it from Dr. Masengel in the morning, that's actually based on studies that were done many years ago, 30, 40 years ago, the ISKGC study that showed that irrespective of what we see on kidney biopsy, the most important factor that will predict who is going to do very well, who's not going to do very well is actually that initial response to corticosteroid. So we pediatric nephrologists, when we see a patient with nephrotic syndrome, we can actually talk about what the long-term outcome is going to be after like about 4 to 6 weeks after making the diagnosis. Okay? Then it turned out that when you do the biopsy, we've heard about the problem with biopsy, just looking at the changes. We're just seeing the changes. What is important is that we need to figure out what's causing the changes. There's actually some relationship between response to steroid and what you see on biopsy. For example, we know that children that have minimal change disease on biopsy, majority of them, not all of them, majority of them will respond to steroid therapy. Okay, and you've seen this many times. So that's what we'll see. So this is what we call minimal change disease. So when you look at the biopsy under the microscope, this is what you see. So you see this lacy-like figure, that's the glomerulus there, unlike this one. So this is FSGS, and where you actually have scarring. However, when you look at both of them under electron microscope, they actually look very similar. What you see is, you see these cells, we call it, the podocytes. You've heard about it, many times today. Actually, I did not bring a very nice picture of podocytes because I know you would have seen it like about 4 or 5 times before it gets to my tongue. Okay, but the way in which I describe podocytes is that it's like an octopus. It has this big head, and then things just coming out of it. So when you look at, for example, if you do not have this and this, and you're looking at this, really you cannot differentiate between this and this because they look alike under electron microscopy, telling us that there are some specific cells that are affected and that are actually common to why people develop the condition. Okay, so I'm not going to take you through all this. But the message from this slide is that there are some form of nephrotic syndrome that we know that are due to dysregulation of the immune system. Okay, and the evidence for that, people have actually provided this evidence so the first classic paper came out in 1974 by from Dr. Shalhoub working in the UK. And what they found is that they think it's due to defect in some immune cell in the body called, the T lymphocyte. And what are the evidence for that? Number one, when some people that have T-cell defects, so they have T-cell defects, for example, lymphoma. Some patients with lymphoma can actually develop nephrotic syndrome. Okay, that's one evidence. The other thing is that most of the medication that we actually use that patients do respond to actually have some effects on the function of the T-cell, the steroid, the calcineurin inhibitors. Okay? All right, so let's jump this. Okay, so based on all this, the evidence here is that there are some genetic components to nephrotic syndrome. And the one that people have actually studied extensively is the variant that is called the steroid-resistant nephrotic syndrome. Here is the problem. Steroid-resistant nephrotic syndrome is responsible, at least in children, for only 20% of all cases. Okay? And the first study was probably in 1998 from a group working out of Sweden and Finland when they identified a mutation in a gene called nephrin. At that time, they call it congenital nephrotic syndrome of the Finnish type, but we now know that congenital nephrotic syndrome due to nephrin mutation is not limited to Finland only. It's present in different populations. And they did some elegant experiments to show that you see the space between those podocyte cells, that space is actually formed by nephrin and by interaction between nephrin molecules. That's actually what this is showing. So since then, and because of improvement in technology, in genomic technology, more than 50 genes as being responsible for steroid-resistant nephrotic syndrome. What are we getting from this? What we're getting from this is that it's actually making us understand the disease better. That's number one. The second thing about it is that it also, what I would have loved to see is we identify one gene and then we understand what it is doing and then be able to take it and actually translate it to improving patient care. That's where the big gap is, and there's a big, translation gap, and that's why what we need to do is actually combine, different approaches. However, from all these studies, some things have came out clearly. First is that the defect is in that cell called the podocyte. The second thing is that we know that majority of patients with genetic nephrotic syndrome will not respond to the first-line therapy, that is corticosteroid. That's the second one. The third point that has came out clearly was the point that I made this morning during the presentation on transplant, that if someone has nephrotic syndrome, if somebody has genetic nephrotic syndrome, when I'm talking to the person in the clinic, I can tell the parents confidently that, well, if this happened, if this child should progress, develop end-stage kidney disease requiring kidney transplantation, at least I can tell you one thing, that the chances that this child will have recurrence of the disease in the kidney is extremely low. The number that you hear people quoting is actually 0 to 8%. What I tell my patient is that it's closer to 0% than 8%. So we know that. The other thing that has come out of this is that some of these molecules, actually, when you now pick them and study them carefully, you discover that there's some medications then that are being used for other conditions that can actually target some of these genes. And what we need to do is actually figure out how we can modify this molecule so that we can use it in the treatment of kidney disease. Okay? All right, so how about the type that is very common in children, steroid-sensitive nephrotic syndrome? So that's about 80%. So I have done a lot of work on steroid-resistant nephrotic syndrome, but I'm a pediatric nephrologist. So at the end of the day, the way in which I look at it is that it seems as if I'm just studying 20% and I'm ignoring the 80%. So I took up this challenge about 8 years ago that I really want to look in depth into genetics of steroid-sensitive nephrotic syndrome. Right, here is the problem with steroid-sensitive nephrotic syndrome. So this is a typical family with steroid-resistant nephrotic syndrome. all the black dots are affected individuals. Actually, this is a family from New Zealand that was reported by my late mentor, Michelle Wynne. So we have like about 24 people spread over like about 5-6 generations and within this family. So with the technology that is available now, if we have the sample from this family, we can actually tell them what the genetic mutation is in a couple of weeks. Now, this is what we have with steroid-sensitive nephrotic syndrome. It's usually sibling peers, either brothers and sisters, 2 cousins or 3 cousins. And in terms of genetic interrogation, it's almost impossible to know what is going on here. Right. So in our group now, we have more than 40 patients like this, sibling peers. We know that most likely they have genetic disease, but we really do not know what type, because we do not have a pedigree that has huge information like this, okay? And that basically tells me that maybe steroid-sensitive nephrotic syndrome is not as simple as steroid-resistant nephrotic syndrome, where you have one gene, one condition, or multiple genes, causing a condition. It may be that steroid-sensitive nephrotic syndrome is actually due to aggregate, defects in different genes and what we call polygenic inheritance. And that was the approach that we decided to follow. Of course, there are some genes that have been identified where they found, maybe they found 7 patients in the family, and then 1 patient is steroid sensitive, and the rest are steroid resistant. I do not know how to interpret that, except that there may be some other things that are actually modifying the disease for the person that is steroid sensitive. But primarily, what that mutation is causing is actually steroid resistant. So that's actually one of it that we described when I was training at the University of Michigan. So it's not only Debbie that is from University of Michigan. I trained in Michigan. Yeah. Okay. And then that's another one from so-called M2 from Michigan. Okay. So the approach that we used is that, okay, why don't we look at these children in aggregate and actually see whether we can identify factors that are common to them? And that's the first problem that will come up is that you do not have many patients. Okay? So we said that, okay, this is a gene-environment interaction, and because it has one unique advantage, there are few things that you can confuse nephrotic syndrome with. Very few things that you can confuse nephrotic syndrome. So if you say a child has nephrotic syndrome, steroid-sensitive nephrotic syndrome, you are sure what you are dealing with. Okay? That's number one. The second thing that is very unique about it is that that's the steroid-sensitive type. Most children would develop the condition in the first 10 years of life. So the approach that we used is, okay, maybe we can overcome the problem of numbers by actually looking at patients that we're really very sure of that are homogeneous. So we said, okay, we're only going to study children who presented before 10 years. That's number one. The second thing is the classic study. When people design study, we talk about case control study. Control, you have to match for age and gender. So we said, no, we're not going to match for age and gender, because the fact that you are 5 years, we match you with a 5-year-old now, it doesn't mean that you won't develop the condition at the age of 8 years. So what we decided to do was actually to use adults who are not known to have the condition. So we carried out the study, and the rationale for it, you are going to hear a lot of this from Dr. Friedman. He's going to talk about the APOL1 story. You've heard about the PLE2R1 study, and then the study from IgA nephropathy. So we decided to concentrate on steroid-sensitive nephrotic syndrome. So what we decided to do is actually look at South Asian children first, children less than 10 years, and we use adult controls without the condition. And then we did what we call genome-wide association study or exome-wide association study on these children. We only concentrated on the region of the genome that is coding for genes. Okay, I'm not going to bug you with all this. So why do we think this will work? Why do we think this approach will work? You want to study small population of children, using a technology where the prescription is that you should study like 50,000, 100,000. The reason why we think it's important, why we think this will work is this. Okay, so these are two conditions, hypertension and diabetes. Okay, so we know that there are so many things that can influence this. Some of the bad things that we do, smoke, people using drugs, infections, what we eat over the course of time, and then the wear and tear of, growing up. So the assumption is that a 5-year-old will not be exposed to all these factors compared with an adult. And that's the reason why we think this may work. So we've been studying children, with this condition, and in our cohort now, we actually have over 1,000 children with nephrotic syndrome from all over the world. So we have DNA sample from them, we have their clinical information, and I am still going to advertise. Please join our study. You join our study. We collaborate with different institutions around the whole world, and that's the only way by which we can answer so many unanswered questions that we have now. So that's just showing the ethnicity of our cohort. And then just to confirm that majority of the patients actually have steroid-sensitive nephrotic syndrome. Okay, so we did the study, and lo and behold, we actually found a region in the genome that all these children actually map to. And we believe this is true because it is a region that actually affects the immune regulation system, what we call the HLA region. Okay, and what was very interesting about this finding is that it actually causes some changes in the amino acid that actually alter the molecule. That's actually what this is showing. So this is what we call the wild type, and that is the variant. Okay? So when you find this in a group, in order to convince people that this is real, you have to replicate it in another group. So that was what we did. So we did it we now try to replicate these findings in European children, and lo and behold, we actually found the same thing. In fact, if anything, it was actually much more common. The effect was actually more in European children compared with South Asian children. Okay, so how about the group that are more severely affected? So it's not common in them, but they're more severely affected. So we decided to use the African American population as an example. Now, you're going to hear it again from Dr. Friedman that one of the big thing that has happened in the last 10 years is actually the identification of variants in this gene called APOL1 among African Americans. And we think that's one of the big reasons why there's excess of kidney disease in people of color. Okay, so we said that, okay, we found this in Asian children. We replicated it in European children. Now, for African American children, the first thing that we need to do is we need to show that it's actually not this APOL1 variant that is predisposing them to this condition. So we therefore did two things. We tested the variant, the HLA variant that we found in patients with steroid-sensitive nephrotic syndrome, and we also tested the APOL1. And the result was actually, okay, so this is just to show that, so nephrotic syndrome is not very common. It's even much more difficult to study in African Americans because not many of them are affected, and basically getting the number is not enough. Okay, you basically do not get enough patients to study. So we looked at a small cohort of African American children, 50 of them steroid resistant, 65 of them steroid sensitive nephrotic syndrome. So we did genotyping for the HLA variant and the APOL1 variant, and this is what we found. So this is the APOL1 genotype. This is steroid-sensitive nephrotic syndrome. This is steroid-resistant nephrotic syndrome. And these are people without the condition. Okay? So what this is showing is, if you look at APOL1 and you are looking at steroid-sensitive nephrotic syndrome, absolutely, from this result, we do not think APOL1 is actually what is predisposing them to developing steroid-sensitive nephrotic syndrome, because the frequency in the controls is actually similar to the frequency in the patient with steroid-sensitive nephrotic syndrome. However, look at resistant nephrotic syndrome, 37.8 and 22.6, almost double. So that was actually very interesting. How about HLA-DQA1? So when we look at, this is the one that we found in steroid-sensitive nephrotic syndrome originally. When you look at that, So when you look at that, obviously we demonstrated the difference in steroid-sensitive nephrotic syndrome, so we're able to replicate it in this group too. However, when you look at steroid-resistant nephrotic syndrome, so just look at it now. So that's it. So these are the patients, and that's the control. It's actually similar. So this is the first time that someone will do genetic study and will actually show that the partition that we've been using, clinical, you can actually use some genetic marker to target, to say that this, if you have this, most likely you're going to respond to therapy. If you have this, most likely you're not going to respond to therapy. So this paper is actually under review now. It's probably going to come out before the end of the year. Okay, so what we've shown clearly here is that this is a risk factor for steroid-sensitive nephrotic syndrome. However, the HLA region is a polymorphic region to the extent that when you find it, what people usually tell you is that there is a second thing that HLA DQ1, that region is actually modifying. And it's actually that second region that we are looking for now. We believe that those variants are likely to be rare, and because the variants are likely to be rare, you need a huge population to study that. And we're actually doing that collaboratively now. Okay, so this is one of the variants that we found in the Asian that we think may explain the difference. This is still very, very preliminary. We do not have enough number to actually say that this is what is driving the differences that we've seen. And that's just showing the structure of that molecule. I won't go through it. It's likely to be important because it's found in that cell called the podocyte. And that's it there in the podocyte, and that's it. And when you actually look at the protein, when you do the blotting. Okay, so what have I been saying? What I've been saying is that nephrotic syndrome is not very common. Therefore, we need to build a community. We need to build a village to study it. If we don't do it, no other person will do it. Okay, that basically there are some genetic predisposition to steroid-sensitive nephrotic syndrome, and most of steroid-sensitive nephrotic syndrome is likely to be due to gene and environment interaction, and therefore we need to identify all the genetic risk and actually pick each of the risks and say which environmental factor is actually predisposing this person to developing nephrotic syndrome. Okay, so most of this you've heard from Dr. Gibson that if we can profile you very well, and when she's talking about profiling, she's talking about genetic profiling, profiling from biopsy, profiling from protein, from blood, profiling from urine. If we know that, then we can say specifically this is what is going on. In fact, it may actually be useful because if we do, before someone develops the disease, if you know that the person has a risk factor, you can tell the person, you are not the type that should be smoking. You are not the type, and smoking is never good for anybody. You are not the type that should be eating greasy food. It's never good for anybody, but it's particularly important for you because you have this risk factor. So it can lead to preclinical diagnosis and actually prevention or slowing of chronic kidney disease. It can lead to better interpretation of those things, and when they look at the biopsy and then they look at it. And so we put everybody in the category FSGS, minimal change disease. FSGS is probably about 1,000 disease. Minimal change disease, probably another 500. So it actually gives us the ability to differentiate things better. And you've heard about drug trials. You had the TNF study. So Dr. Gibson did the trial for the anti-TNF study like almost 10 years now, 10 years ago. Okay? And she's now realizing that actually you can use the same TNF to classify people that if you have this variant in this TNF or you are mapped to this pathway, you are likely or you're unlikely to respond to anti-TNF. So what she's going to do now is that she's going to go back to her whole data and now say the people that did not respond, could it be that they belong to that third group and that did identify them almost 10 years later? So that can actually lead to better interpretation of clinical trial, and it can actually let us understand why some people will respond to some medication and why some other people will not. Of course, we talked about transplantation, APOL1. I'm not going to talk about that because Dr. Friedman is going to talk about that. Of course, when we do all this study, we identify all these targets. The ultimate goal is actually to find a medication that is very, very effective with very, very minimal side effects. And it's by doing all this study, using all this technology that is available, that we can actually achieve this. Okay, so that's from President Obama. I think this is usually my popular round up slide that most medical treatments have been designed for the average patient. As a result of this one-size-fits-all approach, treatments can be very, very successful for some patients, but not for others. So what we are aiming for is that we know your genetic makeup, we know the environmental factors that you're exposed to, we know your lifestyle. And when we combine all these factors, we then say, this is the appropriate medication for you. So it's not one medication for everybody. Right, so that's a recent snapshot of Duke, like last week. Very proud of this institution, okay? So that's my mentor. She actually started this program more than 20, 25 years ago. Unfortunately, she passed on in 2014. We love Michelle. We continue to love her. And that's my group in the lab. And like Debbie said, you know, none of this will be possible without support from foundation. I've gotten money from NephCure, right? Doris Duke Foundation, NIDDK, National Institute of Health, and International Society of Nephrology, and all the good people that I'm collaborating with, and all the good people that I'm working with in my lab and in the hospital. And with that, I will be happy to take questions. Thank you.